all. This is Dr. Mubin Sayed from drbeen.com. Welcome to one more show. So, the discussion today is two studies. One is from Israel and the other one is from China. One study from Israel is demonstrating that Paxlovid or Nirmatrelvir is actually useless for high risk patients who are in the age bracket of 40 to 65 or lesser than 65. And I'll show you the numbers and we'll go over that study. The second study is from China, where they are demonstrating the incubation time of various variants. That is actually very interesting. And just to put a seed in your mind, Omicron's incubation time is about 3.4 in healthy individuals. And that is interesting. And we'll discuss more and we'll look at others as well for a comparison. So these are the two studies. Let's start our discussion. This is drbeen.com. In the description of this video, there is a link to a super enormously discounted one-time price for Dr. Bean, and take advantage of that while that price is available. This is the study, Nirmatrelvir use and severe COVID-19 outcomes during the Omicron surge. This is a supplementary material that I'll go over as well. These are a couple of articles if you would like to read them. I do not know what their political leanings are, so don't call me out on that. I have no idea who they are. And this is the other study about the incubation time. So with this, let's start. So we'll start from here. These are our gifts for humanity. They are continuing and talking about the gifts very quickly. Hopefully I'm not wasting your time. Very quickly, and let me show you this. Do you see this little bean, doctor? So a cool bean from New York sent me this human bean one. So it says, doctors are carrying human beings on the front. And then it says here, I am a human being. And then this is a little one. So thank you very much. It's actually a cool bean doctor. So talking about the gifts for humanity, thank you for this gift. Now continuing. Share my screen again. Okay, so the Israeli study, it's actually a very large study. The overall population for Clalit healthcare system, I think about 52% of the Israeli population is participant in that healthcare system. So they had, I think, about 1.2 or so that were eligible participants. Then out of them, they further did inclusions and exclusion, and we'll discuss that. This study is actually an observational retrospective study. So they looked at the data for the study. It's not a prospective study to say we will start using the drug from today and we'll report later on how the results were. It's a cohort study. The duration for the study was January 9th to March 31st, 2022, both 2022. This was the time where in Israel, Omicron, I think in the most of the world, Omicron was the primary variant. And they did this study because they said Paxlovid's behavior or Nirmatrelvir's behavior and ritonavir, that behavior for Delta is probably known a little more. However, for the vaccinated and unvaccinated, for Omicron, this behavior was not known. So that's why they did the study. So they had finally a total eligible population of 109,524. Out of that population, 4% were actually given Paxlovid because they were deemed high risk. I want to make this clear. I'm sure that this sentence will be missed by many viewers afterwards who will skip around, and then they would make this comment that younger age patients are healthier, so yes, they don't need Paxlovid. That is true, but here the younger age, 40 to 65, were those youngsters who were deemed at risk either because of their comorbidities or because of other such situations, maybe taking a drug which is immunosuppressant and so on. So, this study, both groups that are part of the study, the two groups were 40 to 65 and then 65 plus. They both were given Paxlovid only if they had a high risk. Okay, so back here, 3,902 were deemed high risk and were given Paxlovid. There were 65 plus and lesser than 65, basically 40 to 65. And what were the results? This is very interesting. So, for hospitalization, in those that were 65 plus, treated versus not treated, it is the numbers for hospitalization. So, that is progressing too severe. This is why they were given the medicine, that the medicine would help against that. So 14.7 cases per 100,000, 65 years plus when on Paxlovid. 65 years plus when not on Paxlovid, not treated with Paxlovid, 58.9 cases per 100,000. 14.7 cases per 100,000 versus 58.9 cases per 100,000. That was the impact of Paxlovid at 65 plus community. So clear benefit. The adjusted hazard ratio is 0.27, which means that they are 27% likely to get to hospital compared to the ones that were not on Paxlovid. So that's a very good reduction. And the confidence interval was 0.15 to 0.49. This study has a problem that there are many confidence intervals that are inclusive of the null hypothesis or the null, or meaning these are invalid, but they're out there. So it is your own duty to kind of figure out which confidence intervals are not correct, or which confidence intervals make the data not significant. Okay, so now lesser than 65, youngsters 40 to 65 years of age. Those who were treated with Paxlovid, 15.2 per 100,000 on Paxlovid. And those who were not treated with Paxlovid and were age 40 to 65, 15.8 per 100,000. No difference. No difference at all, actually. So before I go to the hazard ratios, notice something interesting. 65 plus on Paxlovid have a very similar risk of 40 to 65 not on Paxlovid. 15.8, 14.7, 15.2, they're all similar. Actually, 65 plus on Paxlovid are a little better than youngsters on Paxlovid or not on Paxlovid. So for 65 plus at risk patients, it makes sense. Now let's look at 40 to 65, this side, and look at their hazard ratio. Adjusted hazard ratio is 0.74, and the confidence interval is 0.35 to 1.58. So it includes the null hypothesis, so it's kind of not significant. We would simply say no significant benefit was observed. So this is a large study as well. The response to this study should be either we say, you know what, this is a good study, we agree with this data, and Paxlovid should not be offered to younger population. Although if I'm a doctor and I want to do everything for the patient, I would consider Paxlovid. The question is the side effects versus the benefits. Or if the healthcare authorities care, they could actually request a study here, let's say in US or other countries, and kind of try to repeat this. Or they could do as this study did. They went back to data and did data analysis. So I hope there is some outcome, not that it's just, hey, there was another study. Now, one part done. We are still in the summary. Second part of the summary, death. Unfortunately, we have to talk about deaths all the time. So death, 65 plus, 65 plus on Paxlovid versus not Paxlovid, the adjusted hazard ratio, meaning those who are on Paxlovid, what is their likelihood to die compared to those who are not on Paxlovid and had COVID and were 65 plus. So those on Paxlovid had 21% likelihood compared to 100% if we take 100% as a reference for not on Paxlovid 65 plus. So that's a very good number. And if you see here, confidence interval is fine as well. 0.05 to 0.82, a big range, but still lesser than 1. So there is definitely a benefit. So 65 plus have a clear benefit, significantly provable benefit for hospitalization and for death. Now, if you go here to lesser than 65, that is 40 to 65, look at the death adjusted hazard ratio, 1.32. That is more than equal likelihood to die. Although, if you look at the confidence interval, that goes from 0.16 and crosses all the way to 10.75 with a huge range as well. So it's not significant data. So again, these data points here just show that there was no benefit. So there was no benefit. Conclusion. They say, and I put that conclusion over here because sometimes people think I'm just making up these numbers. So it is interesting to just hear from the researchers. Conclusion. Among patients 65 years of age or older, the rates of hospitalization and death due to COVID-19 were significantly lower among those who received Nirmatrelvir than among those who did not. So that is 65 plus. No evidence of benefit was found in younger adults. And please note, when we usually say in the COVID context, the younger, we normally mean 30 and lesser. This is 40 to 65. And still no benefit. And do you know something interesting? 69% of this cohort was vaccinated. And one dose vaccine was actually counted as unvaccinated. 69% were vaccinated. Even then, even with the help of Paxlovid, those who were at risk of becoming severe in the age of 40 to 65 had no benefit of Paxlovid. I mean, these are multiple layers of failure for this age group. Now, some more details. One, I clarified this. Only at-risk patients were prescribed Paxlovid, not everyone, even for 40 to 65. 69% had prior immunity. And what they mean by prior immunity is either vaccinated or infected and recovered, or vaccinated plus infected, or whatever combination, meaning they were previously exposed to this. One vaccine dose was counted as not vaccinated. Now, another thing that was very interesting for me in this one is subgroup analysis. That is analysis for, look at this, among patients 65 years of age or older who had received Nirmatrelvir, the adjusted hazard ratio for hospitalization due to COVID was 0.32 among patients who had previous immunity. Check this out. This is actually a very delicate point. It's a very interesting point as well. It actually made me surprised. We're talking about 65 plus. We are talking about those who had previous immunity, vaccinated, infected, infected plus vaccinated. Those who had the immunity, their adjusted ratio to go to hospital was 0.32, which means 32% likelihood of ending up in a hospital compared to those who did not have Paxlovid, and we are comparing them as 100. So if there are 100 patients who are not on Paxlovid, then there is likelihood of 32% from Paxlovid side. But look at the surprising part. Those who did not have immunity, that means they were not infected before or they were not vaccinated before or any other such combinations, 0.15, 15% likelihood. If they were given Paxlovid, their likelihood, we are still talking 65 plus. So don't say that, well, these were healthier or blah. They're still 65 plus. And they could be healthier. They're not vaccinated. So they must have something to say, hey, I'll be fine. Uh, 15% likelihood compared to 32% likelihood of those who are infected or vaccinated or a combination. This surprised me. I do not know why this. And these confidence intervals are actually interesting as well. They are meaning significant. 0.17 to 0.63, good, valid number. 0.04 to 0.60, valid number as well. So this is an interesting one. It was kind of buried in there, which was not put anywhere in conclusion or result, nowhere. It was just sitting there. Another part, among patients 40 to 64. So same two breakdowns of previously infected or immune by vaccine versus not. Although these numbers do not have statistical significance, so it's kind of useless to read them, but let's read them. Among patients 40 to 64 years of age who had received Nirmatrelvir, the adjusted hazard ratio for hospitalization was 1.13. But look at the confidence interval is not correct. So I cannot dramatize this number at all. For us, it's 1.13 is actually more than one, but cannot be used. However, and this is for the previous immunity, those who didn't have the immunity, that was 0.23. Once again, the number crosses the null, so not significant, but 0.23 versus 1.13. If we were not looking at the confidence intervals, these are very interesting numbers. Once again, 40 to 65 years of age, at risk patients, unvaccinated, on Paxlovid, performed better, much better. So, but not significant data. So I think me saying better or much better is not really interesting. Okay. Then I want to review a couple of tables with you. So one table here. So this is a supplementary PDF. In this, there are a couple of things that are interesting. What was interesting for me was that how did they decide who is at risk? Is that some kind of a, some willy-nilly scoring that everybody is at risk and let's give everyone Paxlovid? But remember, they were not giving Paxlovid to everyone. Over there, we saw 109,000 patients that could have been eligible, but only 4,000 received it. So they were filtering. So here is how they were doing. They said, we have a manuscript of or a checklist of describing with points who of calculating risk score, and then based on that they decide to give Paxlovid or not. And they have here, they're saying their scoring system is very good. For example, they say, for example, at a threshold that identifies only 18% of the CHS population, the Kalalit hospital system population, as having an elevated risk of severe COVID 19, the model, their risk model, manages to capture 92% of the individuals that ended up with severe COVID or COVID 19 related deaths. So it really works very well. Then they said, in addition to the risk factors in the model that I'll go over with you, they added some more factors to it. Those factors are the addition of risk points for unvaccinated or partially vaccinated individuals. So they kind of looked at them and said, okay, they are at risk. Changes to the way points were designated based on an individual's age, with individual less than 60 receiving a penalty and individuals over 70 receiving additional points, meaning they were subtracting some from younger population, relatively younger. The addition points for immunosuppressed individuals. So those who were immunosuppressed, they got some extra points as well. So the more points or the score is, the more somebody becomes closer to the eligibility to get Paxlovid. Now, here is a criteria. It's interesting to just look at it. So I'm not going to go over everything, but just some. For example, age more than 70, 2 points. 50 to 59, remove 1 point. 40 to 49, remove 3 points. Unvaccinated or a single dose of vaccine, add 5 points. Immunosuppression, add 7. Hospitalization, previously 1 point, and so on. So this is a very interesting scale they have. Based on this scale, they would assess someone who could progress towards severe disease. And we can actually use this as well. If we have some feeling that, hey, am I at risk? You can look at it at least that this is a hospital that says this scale helps them identify 92% of the patients who might become severe. So they have this scoring system. The other thing that I wanted to show you was, let me go to their table, characteristics of the population. So here they had 1 million people, 55% were female. Then there was a breakdown of the Jewish, ultra-Orthodox Jewish, and then Arab population, and then other. Here are the clinical risk factors. So you might have that in your mind, that who did they think clinically was at risk. So that was the scoring system we saw. So clinical risk factors: obesity, 144,000 patients were there. Hypertension, diabetes, current or former smoker, immunosuppression, neurological diseases, current cancer disease, asthma, history of stroke, chronic hepatic diseases, chronic obstructive pulmonary disease, chronic heart failure, chronic kidney failure, recent hospitalization, no prior. Then they also had no prior immunity versus immunity. And as I said, their prior immunity definition included vaccine, infection, or a combination. So this is the study. For me, this was really interesting. That fine, the takeaway is 40 to 65 years of age, Paxlovid doesn't do anything. Nothing at all for hospitalization or for death or protection from these. Nothing. Zero. But it's also interesting to see that Paxlovid works better on those who do not have previous immunity. And I think if you ask me that, hey, can you conjecturize this, that why would this happen? This is probably the Prozon or hook effect. And I have been meaning to do one extra video on Prozon or hook effect, but I think nobody's really going to watch it. Nobody cares about what is Prozon or hook effect, but that, I think this is that effect. Okay, so we're done with this study. Going to go to the second study. This study, incubation period of COVID-19 caused by unique SARS-CoV-2 strains. This was very interesting as well. This is a study from China, Beijing, China. So check this out. A total of one, so this was a meta-analysis. They went over the previous studies and did the analysis. A total of 142 studies Can I make it bigger? Yes. With 8,112 patients were included. The pooled incubation period was 6.57 for all variants together, including Omicron and the original, 6.57 days. And the confidence interval is 6.26 to 6.88. So 6 to 7 days. Incubation time, that is, a patient just has the virus multiplying in them, and then they would develop the symptoms on 6 or 7 days. And we had one more study from China that showed that patient would start shedding 2 3 days before, so before the symptoms. So that's the interesting part of this. And also a virus that is more aggressively replicating, whose incubation period is shorter because it is just growing very fast, like Omicron, that would create a bigger load very fast as well. And that could cause more damage, although we know it has other mutations. Okay, back here. Range was 1.8 day to 18.87. So from about 2 days, some people had an incubation period of 2 days or 1.8 days to almost 19 days. That's also very interesting. 19 days. There was a study from China that showed a woman who had an incubation period of 29 days. Okay, so then the mean incubation period of COVID-19 was 5 days for alpha variant. 5 days. Remember, we heard about this all the time. 5 days. 4.5 days for beta, 4.41 days for delta, and 3.42 days. And the range is 2.8 to 3.97 for Omicron. 3.42 days. And some people even lesser than 3 days. And some people about 4. But 3.42 days for Omicron. That's fast. And what I do not know, and what this study does not show, is when does a person start shedding? If it is, let's say, 3.4 days, then do they shed 1 day before, or 1.5 days before, or 2 days before? That's something that is not known, at least not in this study. And this also tells me, when I came back from FSCCC meeting, that was a Tuesday. So somewhere in the travel, I think I would have gotten it. Friday is when I actually became more sick. So Tuesday exposure, Wednesday, Thursday, Friday, exactly 3.5 day. So that seems like an Omicron type thing. Okay, so the mean incubation was 7.43 days among older patients. So older patients had about 7.43 days of incubation. 8.82 days in children. Children, almost 9 days of incubation. So they can really be good spreaders because they're just, and then many of them are asymptomatic as well. They're good with this one. And then 6.99 days among patients with non-severe illness, and 6.69 days among patients with severe illness. So this is the incubation time. Again, 3.42 for Omicron. Their conclusion: the findings of this study suggest that SARS-CoV-2 has evolved and mutated continuously throughout the COVID-19 pandemic. So that is where we say, no shit, genius. Producing variants with different enhanced transmission and virulence. Identifying the incubation period of different variants is a key factor in determining the isolation period. That is interesting. So they say that we are bringing this up so that one can understand how long to isolate. For me, I wish there was a clarity here for shedding. If shedding was there as well, this would be such a beautiful study, because this would tell even more interestingly that when will a person actually start distributing it, and then people can become a little more careful after exposures. So this is the study And I see Rima is here. Let's see if any quick question before we close for today. Margaret says, print size is much better for me tonight. Thank you very much. I was trying to make it big as well. Um, Broken, I'm so sorry. We I just found out I work a huge scammer. Okay, so sorry about that. So let's start closing it. Do you know the good news? In the morning, I sit down and do one more lecture, and now after this, or sometimes before this lecture, I then record it. Today, I'm going to record it after this one. These lectures are going only on Dr. Bean. So those who have bought it, although they have only spent 67 or 97, but still they continue to get one more new lecture every day now, or four new lectures every week. So I'm going to do that lecture after this one. Thank you very much for being here. In the description of this video, there is a link to buy Dr. Bean access. It is a one-time payment, very, very inexpensive, and then affordable and less less burdensome on the wallet. And then there are other links as well. If you would like to support this work, you can buy me a coffee, or you can use PayPal, you can become a patron, you can use Substack, you can become actually part of Dr. Bean YouTube as well. And those members who are Dr. Bean YouTube members, I'm going to try this week that we do a Zoom call that we do, I think, on Thursday maybe. So I would announce and put the link out, and hoping to see you on Zoom. So thank you very much, and I'll see you tomorrow. Stay safe, happy, and healthy. Bye for now.